Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. Thank you for inviting me to UITM First International Online Vestibular Conference. The task given to me is to talk about surgical management in patients with vertigo. So this is the outline of the presentation. Vertigo is an abnormal sensation of movement or rotations of the patient or his or her environment. The physician should get a complete history, ask the patient whether the patient has a true vertigo, and at the end of the history, we should give a correct diagnosis. Surgical management in patient with vertigo, the patient should already have an optimized medication. The patient inadequate response to medical therapy, patient is fully understands about the option, and of course, the patient should fit for general anesthesia. There are two categories of patients. First, those patients who fail medical treatment, such as in benign paroxysmal positional vertigo, Meniere Disease, Canal Dehiscence syndrome, labyrinthitis, perilymphatic fistula. Another group for those patients with a labyrinthine fistula or patient with a vertigo secondary to central cause. Surgical treatment for recurrent benign paroxysmal positional vertigo is for those with the incapacitating BPPV or failed medical conservative treatment. There are two options for surgery. One is singular nerve section, or we can do a posterior semicircular canal occlusion. Singular nerve section was introduced in 1978, and this singular nervectomy is performed through anterior tympanotomy. It can be done under local anesthesia or general anesthesia. The singular nerve is a branch of the inferior vestibular nerve which supplies to the posterior semicircular canal. The anatomical studies report wide variations in the possibility of locating the singular nerve, and there's also difficulty to get a correct identifying the nerve. So this is a schematics view whereby after the anterior tympanotomy, we can identify the promontory, we look for the round window, and we try to look for the round window membrane. So we need to drill the bony overhang over the round window niche and the singular nerve located at posterior inferior to the round window membrane. The hook can be used to transect the singular nerve. Another types of surgery is a semicircular canal occlusion. This can be done via the post-auricular incision followed by cortical mastectomy. So after delineates the landmark for the facial nerve, identify the posterior semicircular canal and the drill of the posterior semicircular canal with the cutting burr, then we can use a bone pate or superficial temporis fascia to plug the posterior semicircular canal. Bayer et al. In 2012 recommended at least 12 months of conservative treatment with continuous verifications of the correct diagnosis before surgery. So this table shows the success rate and the incidence of post-operative hearing loss reported by different authors. So from 1990 until 2015, majority of the surgeons prefer the superior semicircular canal occlusion. So this is the recent study published in 2020, the meta-analysis, and the topic is effectiveness of canal occlusions for intractable posterior canal benign paroxysmal positional vertigo, a systematic review. The last search in 2018. The success rate is 100%. However, the strength of evidence was weak. There is a potential serious complication such as deafness and loss of vestibular function. So now we go to the Meniere disease. So clinical practice guideline was published in Otorhinolaryngology Head and Neck Surgery 2020 in April. So the goal of the Meniere disease treatment is to prevent or reduce vertigo severity and frequency, to relieve or prevent hearing loss, tinnitus, and oral fullness, and to improve quality of life. Similarly, based on the positions by the European Position Statement on Diagnosis and Treatment of Meniere Disease, the treatment approach to Meniere disease after lifestyle modification, medical treatment. If there is fail in a medical treatment, then can we suggest a surgery or combine medical and surgical treatment. So after first line management, modifications of lifestyle, the second line management is intratympanic dexamethasone. This is because there is no risk of hearing loss. Bayer et al. In 2017 showed that the effect of the intratympanic dexamethasone application can have a short-term control. The effective of the dexamethasone injection intratympanic is only 5% to avoid ablative surgery. The Cochrane review by Westerberg in 2011 showed that limited evidence to support the effectiveness of intratympanic steroid. The third line management is endolymphatic sac surgery. There's no significant effect could be achieved using the endolymphatic sac surgery. It is only placebo effect. The Cochrane review by Pullens et al. 2013 showed that there is no significant effect could be achieved using this endolymphatic sac surgery. Therefore, insufficient evidence for the beneficial effect. So this is from the Atlas of Neuro-Otology and Lateral Skull-Based Surgery. So this is on the left, on the right ear. This is the lateral semicircular canal. So you can identify the endolymphatic sac in between the sigmoid sinus and posterior semicircular canal. So there is only a slit of the periosteum, and this is the right angle with the, this is a round knife. There is an incision mix over the endolymphatic sacs. Another study by Wick et al. In 2017, there is a retrospective study from 2022 to 2013. They have 124 patients with Meniere disease underwent endolymphatic sac decompression with a shunt placement. So they have a 3 category. Then they conclude that the endolymphatic sac procedure may benefit from steroid instillations at the time of shunt placement. The next one is intratympanic gentamicin. So the intratympanic gentamicin, because it has a vestibular toxic more compared to the cochlear toxic effect. The effect mainly causing atrophy on the type 1 vestibular cells as well as neuroepithelium. The toxic effect causes dizziness and unsteadiness following the injection can be minor problem. It can resolve by the vestibular rehabilitation. Because of the intratympanic gentamicin success, the vestibular neurectomy is less. The recommended applications of gentamicin is 1 injection of 26.7 milligram per millimole concentration. The patient should have a pre and post procedure hearing assessment. The outcome is assessed by vestibular physiological response by the number of vertigo spells, a bedside evaluations, as well as PEM and video head impulse tests. The intratympanic gentamicin treatment helped to decrease vestibular sensitivity, was effective treatment to control drop attacks. This is published by Wu Q et al. 2019. How about the intratympanic gentamicin versus intratympanic septomycin? The intratympanic gentamicin is favored in United States of America and most European countries. About to change as France, Japan, and Australia, the intratympanic septomycin is preferred to intratympanic gentamicin as a second-line treatment. Shade et al. 2015 done a meta-analysis, is advocated a titration protocol of intratympanic gentamicin injection, 40 milligrams per millimole, being repeatedly until disappearance of vertigo spell. There are a few methods that can use. Another method is anterior tympanotomy, identifying the round window niche, and then you look here, there is the area of the round window, and you can apply the gel form with a gentamicin solution, 20 milligram per millimole. Gel form was applied directly to the round window membrane for 30 minutes. After removal of the gel form, 2 mL of saline irrigation was applied on the round window membrane to remove the residual gentamicin solution. The fifth-line management is a vestibular neurectomy. It is a selective technique to cut the superior and inferior vestibular nerve and keeping the cochlear nerve safe. This is the most efficient technique for drop attacks and for incapacitating Meniere disease. Labyrinthectomy is the oldest surgical method to treat Meniere disease. The technique can be associated with a cochlear implantation within the same stage in a case of profound bilateral hearing loss. Vestibular neurectomy reveals more efficient than intratympanic gentamicin. The authors recommends indicating vestibular neurectomy in patients suffering of intractable vertigo crisis not influenced by medical treatment associated with reversible hearing function. Labyrinthectomy and cochlear implantation. Most authors recommend to associate cochlear implantation to surgical labyrinthectomy. This in order to rehabilitate hearing in the same time. The practice is more common in Australia and United States of America than in Europe or in Japan. It was not allowed in France. Then we go to the international consensus on treatment of Meniere disease. This following IFOS. So the propositions of algorithms of treatments of Meniere disease, again, 80% of patients cure or remission following lifestyle modifications and medical treatment. For those patients with severe intractable Meniere disease, local conservative medical treatment with a dexamethasone and follow up and look at the hearing function. If let's say the hearing is normal, then can go for conservative surgical treatment, or we can go a vestibular neurectomy. Or if let's say there is a not efficient hearing, we can go a local disruptive medical treatment with the intratympanic gentamicin. Treatment of bilateral forms of Meniere disease. 2 to 47% of patients can have bilateral involvement. Bilateralizations occur secondary after several years. Therefore, the most important is to follow up patients with a Meniere disease. Bilateral Meniere disease should be treated in a conservative way to avoid bilateral ablative treatment. This table shows the methods of treatment in Meniere disease and the effectiveness. Again, the effectiveness is high in vestibular neurectomy, and there's also important to look regarding the other considerations such as permanent imbalance, not usual, as well as permanent imbalance and hearing loss. There are many surgery for Meniere disease. So the most important by Cochrane study, Poulet et al. 2013, there is important to look at the type of outcome, the number and severity of acute attacks of vertigo, loss or gains of hearing following the surgical procedure, severity of tinnitus, perceptions of oral-fullness, and durations of symptom correlated to the improvement of the symptom, as well as the complication of the surgery. Now we go to the Canal Dehiscence syndrome. It was described by Miner in 1998. Patient presented with vertigo, oscillopsia, or nystagmus. Sometimes the patient accompanied by conductive hearing loss, pulsatile tinnitus, or autophonia as reactions on loud noise, intracranial pressure increase or increased pressure in the middle ear. There is also presence of Tullio phenomenon and Hannibal sign. A satisfactory control can be achieved by avoiding the situation that caused the symptoms. Only 10% of the patient receive surgical therapy. Benamira LZ 2015 mentions that the vestibular symptoms, hyperacusis for own footsteps, and chewing noise, autophony, stress-related oscillopsia are the symptoms that cause patient decided more frequently for surgery. So there are a few case reports. This one is a case report whereby in a pregnant lady, the patient has a superior and posterior semicircular canal dehiscence. So this CT scan shows there is a dehiscence of the posterior semicircular canal, and there is also dehiscence at the limbs of the superior semicircular canal. So these patients treated with avoidance of the provocating factor and conservative treatment for and this patient go for the conservative treatment. So since the first introductions of superior semicircular canal dehiscence in 1998, there is a recent study, superior canal dehiscence syndrome lessons from first 20 years. This was published in 2017 by Brian K. Watts et al. And they proposed diagnostic criteria for superior semicircular canal. The most important, of course, high resolution CT scan, at least one of the following symptoms considered consistent with a superior semicircular canal dehiscence syndrome: bone conduction hyperacusis, sound-induced vertigo, pressure-induced vertigo, pulsatile tinnitus, at least one of the following diagnostic tests indicating third mobile window, a negative bone conduction threshold on pure tone odometry, enhanced VAM responses, and elevated submitting potential to action potential ratio on electrocochleography in the absence of sensorineural hearing loss. So now the question here, superior semicircular canal dehiscence, whether it's congenital or acquired. It's very interesting. This study published in 2011. So they look at the prevalence of superior semicircular canal dehiscence. So it is increased with the age of the patient. So they conclude that the increased radiological prevalence of semicircular canal dehiscence among all the age groups suggests that this is more commonly an acquired rather than congenital condition. So now we go to the surgical treatment for superior semicircular canal dehiscence. The most important is to look at the preoperative CT scan. So in this case, there is a dehiscence of the superior semicircular canal. Look whether there is an involvement of the petrosal sinus. If let's say it's involved, you can't do a medial craniofossa approach. This is from Mayo Clinic. So repair of superior semicircular canal dehiscence via medial craniofossa approach by Neil S. Patel, Mayo Clinic. So after craniotomy, elevating of the dura from anterior to posterior until you identify the superior semicircular canal dehiscence. Then the bone wax is placed over the dehiscence, followed by the cottonoids or neuropathy. You just compress over the dehiscence, and followed by temporalis fascia over the bone wax. I never did this with the neurosurgery in my center. Another study published in Archive of Otorhinolaryngology 2014, the superior semicircular canal via the medial fossa approach. So this technique called capping, the success rate is 89%. Now we go to the clinical outcome medial fossa craniotomy for superior semicircular canal dehiscence. So this was published in 2016. All patients reported resolution in more than one symptom associated with superior semicircular canal dehiscence. and 29% has developed imbalance as complication post-operatively. 20% of patients develop sound and or pressure-induced dizziness, and 18% of patients develop oral fullness. Superior semicircular canal dehiscence surgery via medial fossa approach carries the complications such as hematoma, seizures, intracranial bleedings, brain edema, or meningitis. Now we go to the transmastoid superior semicircular canal surgery. So these pictures from the temporal bone dissection, just to show there is a facial nerve here. So the posterior wall is already brought down, and this is a lateral semicircular canal. This is posterior semicircular canal. We should identify the superior semicircular canal over this area. So you can watch the YouTube, the transmastoid plugging of the superior semicircular canal. So identification of the superior semicircular canal. Then you make a hole over the anterior part of the superior semicircular canal, put a superficial temporis fascia. Then you can also put it on both sides and cover this area with a bone pate over the area of the labyrinth. In general, the success rate of the different surgical therapies reach from 75 to 100% for occlusions, resurfacings, as well as a capping technique. The complication of semicircular canal surgery is either hearing loss, injury to the inner ear causing hearing loss, vertigo, the developments of BPPV was independent from the different approaches or surgery technique. This complication should be informed to the patient preoperatively. So the current topics in otorhinolaryngology, this published in 2017, showed that the decision made together with the patient. So after failed conservative treatment, when the patients want to go for surgery, the patient should be understand about the risk and the success of the different surgical procedure. Now we go to the microvascular decompressions for vascular loop. So there is a term, vestibular paroxysmia. This term given when the patient have brief attacks of spinning or non-spinning vertigo, which lasts a fraction of a second to a few minutes. It occurs with or without ear symptoms such as tinnitus and hypo or hyperacusis, which instability of posture and gait. Attacks may often be triggered by particular head position or hyperventilation. It may be influenced by changing the head position. So the vascular loop, the classification by Chavda grade 1, when there is a presence of the vascular loop, but it's not going into the internal auditory meatus here. So Chavda grade 2, when the vascular loop enter into the internal auditory meatus, less than 50% here. And Chavda grade 3, when the vascular loops close to the distal end of internal auditory meatus. So this is very interesting. The vascular loop in the anterior inferior cerebellar artery as identified by magnetic resonance imaging and their relationship with otologic symptoms. So from this paper, independence between the MRI finding and the clinical profile suggestive that there is no direct or exclusive relationship between the diagnosis of vascular loop and the otoneurological profile. This is also the recent paper published in 2020. The presence of the vascular loop in patients with audiovestibular symptom, is it a significant finding? Evaluation with 3 Tesla MRI 3D constructive interference study states sequence. So in this paper, they classify with the no contact, direct contact with the eight cranial nerve, and direct contact with mild angulation to the eight cranial nerve. So the presence of the vascular loop in contact with the eight cranial nerve is not certainly considered pathology, but possibility to be a normal anatomical coincidental finding. The microvascular decompression, so just to put a picture here, that when there is a decompression of the vascular loop, the neurosurgery normally put a separations between the vascular loop and the eight cranial nerve. They can use a Gore-Tex or they can use any inert material. The microvascular decompressions of the cochlear vestibular nerve for the treatment of tinnitus and vertigo, a systematic review and meta-analysis of individual patients' data. This was published by Journal Neurosurgery in 2017. So they conclude that due to low success rate, microvascular decompressions cannot be considered as a standard treatment methods for tinnitus or vertigo. This meta-analysis individual patients data of 165 patients demonstrated that patients with both tinnitus and vertigo had a higher chance of success compared to patients with tinnitus alone. Now we go to another group of patients, labyrinthitis. Okay. When the patient has labyrinthitis, there is considered as an emergency whereby the patient presented with severe otalgia. Maybe the patient has acute labyrinthitis secondary to acute otitis media and mastoiditis. Therefore, the patient should go for cortical mastectomy. If the patient has bacterial labyrinthitis secondary to a cholesteatoma, the patient should go for urgent modified radical mastectomy. The preoperative CT scan is crucial, and the aim is to eradicate the disease and to prevent complications such as meningitis and mastoid or autogenic brain abscess. The principal management of perilymphatic fistula, we need to have a high index of suspicion whereby the patient presented with fluctuating hearing loss, and normally the patient had surgery of either a stapedotomy, or the patient also can have a perilymphatic fistula secondary to trauma. The preoperative proton odometry and high resolution CT scan can help in terms of the diagnosis, and the patient in this category should go for surgery after failed conservative treatment. So the consent is for exploratory tympanotomy and repair of the perilymphatic fistula. So this procedure is very dedicated and requires skills and experience. Now we go to surgery is the treatment for labyrinthine fistula. So labyrinthine fistula is erosions of the endochondrial bone overlying the semicircular canal, commonly due to cholesteatoma. So the investigation here, hearing test as well as CT scan. So this CT scan axial view shows a soft tissue density inside the mastoid, and there's also exposed of the lateral semicircular canal. So it can classify into small, medium, or large depending on the size of the fistula. We go to the principal management. The surgeon should remove all the granulation tissue or cholesteatoma over the other area first before they close the fistula. Then harvest the superficial temporal fascia, remove the matrix of the cholesteatoma gently, leave the perimetric on the fistula. This patient in a patient with a conductive hearing loss or mixed hearing loss. Do not suck over the fistula. Cover the fistula and the perimetric of cholesteatoma with the superficial temporal fascia. and the patient need to have a second look surgery or imaging 6 months post-operation. The principal management, those patients with a profound sensorineural hearing loss secondary to labyrinthine fistula, the surgeon should remove the matrix and perimetric of the cholesteatoma gently and cover fistula with the superficial temporis fascia. Now we go to the central cause of vertigo. So when the patient has a large acoustic neuroma with vertigo, or patient has a meningioma or secondary brain tumor, either from lungs or breast, which compress into the brainstem or to the cerebellum, these patients require urgent surgery. So this is preoperative pure tone audiometry shows a profound hearing loss on the left side, and MRI shows there is a acoustic neuroma on the left internal auditory meatus extending to the cerebellopontine angle. So another MRI shows there is a tumor of the cerebellopontine angle, which is acoustic neuroma. You can see there is a widening of internal auditory meatus, and this tumor compressed into the brainstem. I just want to share my case. Case number 1 is a 33-year-old Malay female. She has a right reduced hearing and tinnitus since 2018. There's no history of vertigo. And on the MRI, there is a small intracanalicular acoustic neuroma. Because of this patient has severe hearing loss, after discuss and this patient opted for translabyrinthine approach for excisions of acoustic neuroma in November 2019. Alhamdulillah, post-operatively patient well, there's no complication intra and post-operatively. Compared to case number 2, 41-year-old Malay female with unilateral hearing loss, tinnitus, she has dizziness, she underwent uneventful translabyrinthine approach for removal of acoustic neuroma. Unfortunately, this patient developed imbalance and dizziness and required a long-term vestibular rehab in our hospital. So from these two cases, I think it is better to operate early in patients with intracanalicular acoustic neuroma with a severe to profound hearing loss. This must be discussed with the patient in length, and the patient must be agreed for the operation. For meningioma, so meningioma is common in second common as a cause of cerebellopontine angle tumor, and this surgery normally done by the neurosurgery via the retrosigmoid approach. The future research direction, I think, because of vertigo is common, so there will be future research on the diagnosis and future research on the medical treatment. Recent study done on the imaging, so a synchrotrons and micro-CT study on the human endolymphatic duct system. So this is very interesting. It was published in a front surgery in 2021. So they can measure or can show to us regarding the normal, the anatomy of patient. We can show in terms of the bony as well as membranous labyrinth. The take-home message, surgery only for the relief of intractable vertigo after failed medical treatment. Be careful about wrong diagnosis. Dizziness from migraine mistaken from Meniere disease or other condition, as many persons with the Meniere disease have migraine. Surgery possible cause more damage than good. Minor ear disease replaced by substantial surgery damage, such as mild Meniere with migraine treated with a destructive surgery. BPPV treated by canal plugging resulting in inner ear damage. In conclusion, patient who nonetheless need surgery for BPPV should undergo occlusions of the respective semicircular canal. Severe vertigo in Meniere's disease, intratympanic steroid or intratympanic gentamicin are the option before vestibular neurectomy. Surgery is the treatment for labyrinthine fistula with cholesteatoma. These are all the references. Thank you.